go back and recap just a little bit. I'm going to share my screen. And I think it's really important that we do get the information correctly from what the research has to say out there. And I think there's some very exciting things that have been published over the last few years. And I think it's something that I would like to share with you. So if anybody has interest in these abstracts, send me an email. There's my email at the bottom, and I'll be glad to send you a copy of it. Okay. These are all I started, the oldest one was 2012, just because I thought it was so topical to the subject. And, you know, they're nothing less than 2017 and the other 18 that I've got up there. 2016, there's one from Lancet. And we'll go through them one by one, then we'll open it up for discussion. So I'll run you down the path that I went through to develop this. All right, this first one's from the British Journal of Psychiatry. And this was back in 2012. And it said here, the efficacy of psychopharmacological treatments has been called into question. Psychiatrists are unfamiliar with the effectiveness of common medical drugs. And so I highlight and bolded everything I thought was the most important parts of this. The increment of improvement by drug over placebo must be viewed in the context of disease seriousness, suffering, induced, natural course, duration, outcomes, and adverse events. So we do have this constant comparison to placebo. And I think that's what a lot of people don't understand. When they compare a medicine to placebo, they have to give that in their reports. They have to give it in their studies. How much over placebo was there? Well, a lot of times they won't report that number over placebo, just a point of, it will just report its effectiveness. So you have to read the actual studies to understand how much above placebo, and 20 to 30% above placebo is not unusual. So, but that's not that effective when you really look at the grand scheme of things. It may be 60% effective, but only 20% over placebo. So mine is a wonderful thing. The next one is the big article that got me really motivated this spring to start two different studies, which we're about to conclude right now. This was from World Psychiatry, February 2022, the efficacy of psychotherapies and pharmacotherapies for mental health disorders in adults. Now, let me tell you, World Psychiatry is the #1 read psychiatric journal in the world, and an impact factor is what you want to look at. The impact factor of most journals is somewhere between 1 and 5. The impact factor I looked at yesterday on World Psychiatry is in the 70s. So it's a big journal. I belong to the World Psychiatric Association. I'm an associate member. I went to present with a bunch of psychiatrists, 10,300 of them in Berlin in 2018. And I'm involved with the neuropsychiatric electrophysiology section of the World Psychiatric Association. So they're a big deal. And I want to publish our next two studies in them for sure. But they say mental disorders represent a worldwide public health concern. Why psychotherapies and pharmacotherapies are recommended as first-line treatments. Efficacy may be overestimated. You know, the majority of effect size for target symptoms were small. Effect size is just a statistical term that actually talks about what kind of impact it has on the population. Risk of bias was often high. After more than half a century of research, thousands of RTCs, and millions of invested funds, the effect size of psychotherapies and pharmacotherapies for mental health disorders are limited, suggesting a ceiling effect for the treatment research presently conducted. A paradigm shift in research is required to achieve further progress. This is really an important statement here. In the conclusions, they repeated it, and it says, is not presently sufficiently addressed by the available treatment. So it's talking about mental disorders. They're just not being addressed by the treatments we have out there, and a paradigm shift is needed to achieve further progress. And I think that's where we are in the field right now. We've been medicating, psychiatrically medicating people based on symptoms ever since about the big push started, I guess, in the 50s and 60s. So, but right now we're seeing there's just no traction to it. Improving treatment strategies for mental disorders can be regarded as a central health challenge of the 21st century. So I think that was a big paper. Now, Lancet Psychiatry in 2021 The use of SSRIs for the treatment of depression and anxiety in young people is increasing. However, the effects of SSRIs in adolescents at a time when there's substantial change in the neurocognitive and social functioning are not well understood. It is crucial to characterize mechanisms underpinning the risk and benefits of SSRIs in this age group and narrow the chasm between the widespread use of SSRIs in youth and the science to which it is based. Okay, so this is the deal that we're having here right now. SSRIs are coming into question, and a lot of people are being put on SSRIs based upon presenting of anxiety. Now, one thing that I used to work inpatient psychiatric at a hospital in Arlington, Texas, 4 years, 3 months, and a day. Not that I was counting, but it's really interesting to get a little snapshot look into that world that is based on crisis. If they're in imminent danger to self or others, they meet criteria for inpatient psychiatric treatment. But what can you do in 7 days? Nothing can come up to, no medicine can take its full effect in 7 days unless you're talking about stimulant or a benzo. So that's one of the things. SSRIs take 4 to 6 weeks to get really up to therapeutic strength. So what are we doing with the SSRIs? Why is there such a large number of young people that contemplate suicide when they're put on SSRIs? I could start a whole session of that discussion with Dr. Vaughn on that part of it too. All right, current neuropharmacology background, another good, a good, beautiful journal out there. And they came up, they said SSRIs and anafranil, tricyclic, and tetracyclic antidepressants in combination with cognitive behavioral therapy and ERP is associated with optimal response to each treatment alone or to other treatments. New strategies for refractory OCD are needed. So we're not really hitting what we need to target with the OCD as well, in spite of trying a combination of medications. OCD is very hard to treat. And I don't know this journal personally, but it had some interesting things. Every one of these journal articles came by accessing PubMed Medline. You type in PubMed Medline into a word search, and you'll get the National Institute of Health's library of credible journals. If they're not credible, if there's what we call, really not want to read these that can be too full of bias and they don't meet the standards for National Institute of Health, they won't put them in there. So PubMed Medline is where I did all my searches. Back to SSRIs, have a profound effect on the circadian rhythm response to environmental light, which may impact treatment outcomes for patients depending on their habitual light exposure pattern. Basically, evening types being the people that like to be the vampires out there. They wake up at late and they go to sleep real early in the morning. They have higher numbers. Evening types have reportedly taken higher numbers of antidepressants in the previous 5 years and lower SSRI efficacy than morning types. So people who are shift workers and young people who love to stay out late at night and everything else, maybe that may have some impact on the efficacy of their SSRIs, something I wasn't aware of. While undergoing SSRI treatment, evening types also reported more depressive symptoms and suicidality. So I always said graveyard shift is called graveyard shift for a reason. And it's those hours, nothing good happens after midnight, guys. I guarantee I was a firefighter for 20 years. I'm retired, and I know that for a fact. It is concluded that the time of day preference may prove informative in predicting SSRI treatment responses. Good information. So when one child wants to stay up late and they're on an SSRI, you say, well, you realize it's going to make your SSRI efficacy go down, and likely your anxiety is going to go up. Panic disorder. Selective serotonin reuptake inhibitors and benzodiazepines are the most frequently prescribed for this. Despite their usefulness, panic disorder SSRIs are associated with delay of several weeks in onset of therapeutic effect, and they have potential to exacerbate anxiety and panic in early treatment course. So that's like I was saying, in the actual SSRIs, it takes 4 to 6 weeks to get up to that level. So if you're having panic, that's like immediate issue. That brings me to the benzodiazepines, all your PAMs, all your Klonopins, all your Xanaxes, all that kind of medication that gives you an instant really good buzz. but they are very addicting. They're rapid action, but they can cause tolerance and dependency. From the very first dose you take of a benzodiazepine, and I know in the 70s they came out real hard and heavy with Valium. You build up a tolerance to them so quickly that you have to have a little bit more with every day, week, or whatever of treatment of this. They were never intended to be used in long-term chronic prescribing methods. It was never intended for that. It was only intended, you had a loss in the family, you're going through a grieving process, you have to get to sleep, they should give you 5 to 10 pills, and that's it. Let's get you through the emergency. But I see too many people that have been on their benzos for years, and you want to have somebody choke you out, just tell them you'd like them to stop their benzos, and they don't want to turn loose of it. It's really tough to get people off of them. So I tell them, don't worry, it's going to go very slow. It may take a year to get some people off of the benzos without going an inpatient. That's very painful. So despite strong evidence to the effectiveness of SSRIs and benzos in the treatment of panic disorder, few trials have been performed in head-to-head comparisons of these two drug classes. And as I've presented in the past about signaling excessive beta and neuroinflammation, possibly underlying panic disorder, that would tend to tell us that SSRIs are going to be contraindicated just because they increase beta and make the activity worse. European Neuropsychopharmacology. This is another good journal. This is 28 random controlled trials. Clozapine was first significantly more effective than all others analyzed in antipsychotics. Nearly all the antipsychotics were more effective compared to placebo, but risperidone, suppressone, sorry about that, showed no efficacy. So it's interesting that we have these things in the research, and very little is known out there when they prescribe these things to us. In terms of preventing weight gain, these are all the different types of medications. Again, if you want these specifically, I can send them to you. Were benign, meaning they didn't cause any weight gain. The highest weight gain was found with clozapine, Seroquel, and olanzapine. Just to give you that bit of that information. Most antipsychotics had some sedating effects. Risperidone, Haldol, paliperidone, olanzapine were associated with prolactin increase. And what happens when you get prolactin increase in young males? Gynecomastia, they actually start growing boobs. Not a good plan. I've actually seen guys have to have mastectomies by the time they hit 21 years or 22 years old because of the high doses of risperidone that they were taking. The side effect that everybody should be aware of. Most comparisons were only based on one study or just on indirect evidence. Again, evidence for these drugs is very shallow, and we got to know that. And yet, sometimes that's all we have. All right. So next, expert opinion pharmacotherapy. Random controlled trials have evaluated the efficacy of antipsychotics in autism spectrum disorder and disruptive behavior disorder. There is evidence to support the short-term efficacy of risperidone, and this is Abilify, and for the irritability in autistic spectrum disorder, and the short-term efficacy of risperidone for aggression and disruptive behaviors. So there is some efficacy for that short-term. Although the benefits are closely balanced with an increased risk of metabolic, hormonal, and extrapyramidal adverse effects, the tardive dyskinesia that you see advertised on TV, and there's medicines for that right now. Never good to see that happen in a child or a teen or an adult either. The use of antipsychotics in children with these disorders should be reserved for those refractory, meaning refractory in these terms regards to failing 3 medications or more. Some people consider 2 medications or more, so that's what they call refractory, failing to respond to the treatment. In whom there is persistent and serious risk of harm to self or others. So that's what they're saying. These are crisis medications. Crisis medications. They should be reserved for those that don't respond to anything else, and that there's a persistent risk for them to harm themselves or others. They actually really dull the person. they will take the excitatory neurochemistry out. They reduce it. So yes, we can drug each other your drool, but is that the best treatment in an emergency situation to keep them from harming themselves or others? Totally agree. But for the long-term use, we should come up with other plans, I think. Antipsychotics should be considered short-term strategy while psychosocial and behavioral therapies are continuously employed. Now, the original article I talked about from World Psychiatry, it said that both psychotherapies and pharmacotherapies were not showing to be very efficacious. However, my hypothesis is that if they're on the wrong medication, psychotherapies have a hard time working well in this population. If they're not on, so we got to take that with a grain of salt. Do we want to look at why these medicines work and why they don't work? So, next study, child and adolescent psychopharmacology. The use of atypical antipsychotics, Seroquel, Risperdal, all these kind of stuff, Abilify, in pediatric patients has become more prevalent, of course. Emerging evidence to the efficacy and tolerability of antipsychotics has been expanded exponentially in recent years. However, more information is needed so that evidence-based comparison can be made and medicines can be made. It's hard to get the studies done with children and adolescents just because it's such a risk. It takes a heck of an IRB, Institutional Review Board approval. In the future, data enabling the selection of medications based on individual patient characteristics could potentially lead to greater efficacy and efficiency in treating what we are frequently like debilitating medical conditions. I like that statement, and that's why I've been doing the work in this area of EEG to help the psychiatrists guide medications, because we need to base it on the individual, not on a group of symptoms. Let's look at the brain. Maladaptive aggression in children often treated with antipsychotics is one such area where there is a dearth, meaning a lack of actual information available to the clinician. Long-term studies of these medications will further inform evidence-based practice. So, PLOS One is a big medical journal, that's out there, high impact factor. And it talked about for this is their big meta-analysis of random controlled trials. Meta-analysis just means they got a whole bunch of these studies. They were able to look them up and look at their tables and everything else and try to compare apples to apples. Okay.
Yeah, you better put on that.
I think someone has their.
Got it? Okay. Thanks. All right. Let me see. When we aim to compare the efficacy, it's not still muted. Kelly. Got it. Thank you. All right. I think we got it. Okay. When we aim to compare the efficacy of safety of pharmacological and psychological and complementary alternative medicine interventions for the treatment of ADHD in children, since this is primarily most of the people who jump in on this from the parents and the school side are all about the ADHD. Behavioral therapy in combination with stimulants seems to be superior to stimulants or non-stimulants, meaning non-stimulants being more like the alpha-2 agonists we're going to talk about in a bit. Or the selective serotonin reuptake, norepinephrine reuptake inhibitors that they have out there. Clinical differences may exist between pharmacological and non-pharmacological treatments used for the management of ADHD. Uncertainties about therapy and balance between benefits and cost and potential harms should be considered. There's urgent need for high-quality randomized trials and multiple treatments of children with adolescents, and that's been, the cry has been out for that since stimulants started, and yet we still don't have those large trials because a medicine can get FDA approval for the treatment of children in a very small number of children that they actually do the study on. It's amazing that Big Pharma can get a lot of stuff through the FDA that I think should be studied more before they get it through the FDA. This is just a neuroscience journal. Current research has shown that neurofeedback is a viable treatment for the attention deficit disorder However, having pharmacological approaches alongside such stimulants is still inevitable. That's good to know. These find that we have found also that when we start doing neurofeedback with kids, sometimes we'd say keep the stimulants on until we can let the brain readjust itself so they won't be needed, because sometimes if you can't keep the child in the chair, it's hard to do neurofeedback. So, as we well know about that. These findings suggest that neurofeedback is efficient in improving some of the behavioral contaminants of ADHD in those children whose parents favor non-pharmacological treatments, but Ritalin and neurofeedback is more efficient. Okay, good. Neuroscience Biobehavioral Review, methylphenidate, which is a stimulant. You have two types of stimulants. You got the methylphenidate and you've got the amphetamine class. Methylphenidate would be more like your Concerta, your Ritalin, Daytrona, that kind of stuff, and then your amphetamines would be your Vyvanse and your Adderall. Two different approaches, slightly different impact on the brain, but there is a specific pattern for each one of those. But concerns have been raised about potential adverse effects of extended treatment on growth. So everybody asks about this, will it stunt your growth? Well, this is a published study in 2021, so it's pretty darn current, guys. Meta-analysis looking at growth in children with long-term ADHD treatment. Long-term treatment with methylphenidate can result in a reduction in height and weight. However, the effect size are small with possible minimal clinical impact. Long-term prospective studies may help clarify the underlying biological drivers and specific mediators and moderators. So, how small is small? They didn't really get into it, but there is some effect on growth, it says. Expert review in clinical pharmacology. Methylphenidate remains first-line medication treatment in ADHD in adults. I will have to say, compared to the amphetamines, I think methylphenidate wins out in most cases. But like I say, I'm not against medications. It's just we'd like it to target for a reason. However, it is behaviorally however, its behavioral pharmacological similarities to methylphenidate and cocaine have historically created concern for its potential as a drug of abuse. And we see that too. People are grinding up the medications or snorting them or whatever, and that's kind of sad. And then it can lead, we're looking at methamphetamines. Where's the amphetamine part? Yes, exactly right. Several studies indicate that methylphenidate has at least some abuse potential. Methylphenidate, amphetamine, methamphetamine, cocaine overlap in their subjective reinforcing and discriminative status effects. Regardless, methylphenidate remains an efficacious treatment for ADHD in children and adults when properly adhered to, especially when paired with non-pharmacological treatments. And Pam has had quite a few presentations by a lot of people in this area, and this is what the research says. Expert opinion on pharmacotherapy. Attention deficit disorders commonly occurs in children, adolescents, and adults. Not all patients are appropriate candidates for the treatment of these drugs. I love it when they say that because it's true. Not everybody is appropriate for these drugs. What is GSR? Oh, well, guanfacine is extended release. Guanfacine is an effective treatment for ADHD and has different side effect profiles than most stimulants. It is not impressive in reducing symptoms. Guanfacine is an alpha-2 agonist called Intuitive. And Intuitive was an old, guanfacine was an old blood pressure medication for adults that got indications for ADHD in children. Very interesting medication. And in some children, it does work well. And we know the pattern it works well in because it has to do with perfusion to the frontal lobes, which is not in all ADHD children, perfusion issues. But in this subset population, especially the children with have issues with sleep maintenance, they get up in the middle of the night, can't get back to sleep, and connected with it's a disorder of hyperarousal, but it's because they've got this excessive amount of slow and excessive amount of fast. And so guanfacine is a non-stimulant, and it's good in chosen about we estimate about 25% of the population in general. In the ADHD population, probably a little bit higher. Despite the availability of multiple pharmacological treatments for ADHD, there remains an unmet need for the formulations as potent as stimulants, but with fewer side effects. Nice statement to have at the end of the study. This is a 2021 study of progressive psychopharmacology, biological psychiatry. Research in pediatric psychopharmacology of autistic spectrum disorders faced with three major hurdles. Great individual variability in this clinical response and side effect sensitivity, because I worked a lot and published a lot in the area of ASD, and I will tell you those brains are radically different, even within their ASD population that I look at. So I'm more so than the normal, the typicals that we see. There's low level of predictability would benefit from symptom-specific treatment algorithms, and I disagree, but that's all right, and from biomarkers to support drug choice. I agree with that one. So the biomarkers is what we're looking at. What indicates that this medicine would specifically help this brain? Symptom-specific treatment algorithms, symptoms are symptoms. They're not the diagnosis. To this date, there's no psychoactive drug appears to directly ameliorate core autistic symptoms, although some indirect improvements have been reported with several drugs. Again, if they knew which populations and they could target their populations better, I think they would be much more efficacious, but they would rather not target their populations better for several reasons, but I'm not going to get into that. JAMA had a 2021 article out talking about the alpha-2 agonists and stimulants for children with ADHD. About 25%, boy, I was right, wasn't I? Treated with alpha-2 agonists. Medications despite minimal evidence about their efficacy or adverse side effect range. This is 497 preschool age children with ADHD receiving alpha-2 agonists or stimulants. That's tough. I don't like stimulants. I'm going to keep my personal opinions out of that one. Improvement was not noted in the majority of children who received the alpha-2 agonist because the majority of children don't have the pattern, with different adverse effect profiles between medication classes. Further research is needed in randomized controlled trials to compare its effectiveness on this versus stimulants. Again, we're trying to treat a set of symptoms that we call ADHD with multiple neurological abnormalities that can create those same symptoms. Tough to hit. Lancet, big journal, 2016, major depressive disorder, one of the most common mental disorders in children and adolescents. However, whether to use pharmacological intervention in these populations and which drugs should be preferred is still a matter of controversy. They wanted to compare. So they've got quite a 34 trials, 562 participants, 14 antidepressants. For efficacy, fluoxetine, which is Prozac, was statistically more significant than placebo in terms of tolerability. Fluoxetine was also better than duloxetine. Patients given imipramine, venlafaxine, duloxetine had more discontinued due to adverse effects than those not given the placebo. So there are side effects to these medications. When considering the risk-benefit profile of antidepressants in the acute treatment of major depression, these drugs do not seem to offer a clear advantage for children and adolescents. Fluoxetine is probably the best option when considering pharmacological treatment is indicated. Now, I know that fluoxetine is the one, and Dr. Nick can correct me if I'm wrong, that they do have the indications for the treatment of anxiety and depression in children, but it's about the only one. Cochrane Database Systems Review, major depressive disorder have significant impacts on children and adolescents, including on educational, vocational outcomes, interpersonal relationships, and physical and mental health well-being. There's an association between mental health disorder and suicide ideation, attempts, and suicide. 26 studies. Most antidepressants may be associated with a small and unimportant reduction of depressive symptoms. 26 studies said most antidepressants have a small or unimportant reduction in depressive symptoms. These results were small and important differences between most antidepressants and the reduction of depressive symptoms. Again, in most studies, the risk of self-harm or suicide was an exclusion from the criteria. So in this study, even though they excluded those that were at risk for self-harm and suicide, they still had very little impact on, if any, on the actual what they were trying to treat. Proportions of suicide-related outcomes were low for most, included studies, and 95% confidence interval were wide for all comparisons. Again, they excluded the ones that were likely to commit suicide or to attempt to think about it, and yet, proportions of suicide-related outcomes were low. Well, of course they would be. They excluded all those people, but we don't exclude them from our treatment. Evidence is very uncertain about the effects of mirtazapine and all these other medications, suicide-related outcomes compared to placebo. Uncertain. We don't know if it helps or if it hurts. It's in between. So the statistics don't support it. There's low evidence that azathioprine may be least likely to reduce the odds of suicide-related outcomes compared with placebo. Fluoxetine, sertraline, that's Zoloft, and venlafaxine may be the least likely increased odds of suicide. Well, that's nice to know. If you want to use one, you should know which ones are the least likely. There is moderate certainty evidence that venlafaxine probably results in the least slightly increased odds of suicide. That's another one, as compared with these other two medications. So again, that's why I'm saying I'm offering these studies to anybody that wants them. They can look at it, pick through the medicines, and see what they may be on. These are using the generic names, not the brand names. Author's conclusion: methodological shortcomings of the randomized trials make it difficult to interpret findings with regard to the efficacy and safety of the newer antidepressants. Findings in this suggest most newer antidepressants may reduce depression symptoms in a small but unimportant way to compare to placebo. And that's one of the things that I was looking at 3 or 4 weeks ago. There was a report came out, and I saw it in the news feed. I didn't see the actual abstract of it. But since SSRIs came out in in the 60s or maybe late 50s, it doesn't show any efficacy compared to placebo. And yet we've been using them and using them and using them and using them, and the efficacy is just not there. So I thought that was quite an interesting article. Again, repeating the same thing about the effect size. They're saying sertraline, which is Zoloft, and you've got the Prozac and the other two medications here. They're currently the first-line treatment in first-line prescribing to consider as the first option, even though the efficacy is not really there. But what else can you do? And again, in the trials, children at risk of suicide were frequently excluded. So if your child's suicidal and we go to a doc and you say, well, we want to try them on this, and well, they were excluded from the trial. So how do we know it's going to work? That's why I wanted this to be out there. We need to know what the research says about it. It's a cost versus reward, reward versus risk. You got to make that judgment as a parent or a person. Consideration of psychotherapy, particularly in cognitive behavioral therapy, as per guidelines recommended, remains important. So they really always come back to psychotherapy, and I'm glad that they do. So that was a quick run through all 18 studies, and I did that on purpose just because I would like to get you these studies. My main point about this is, and I'm going to open up for questions in just a minute, is that we need to be aware of this. There's no magic pill out there. I think the doctors like Dr. Bryant out there are absolutely, some of the more senior ones, I should say, are geniuses and are artists with medications because they have that great gut level feel and they know which types of patients would respond better to which medications. And they nail it 30, 40, 50% of the time, but sometimes they don't. And so, when we look at medications, we have to I want people to be informed. That's the most important thing. An informed population is great. And I think it's going to make a difference in your decision-making processes when you go and talk to the psychiatrist. Like I say, get these articles, feel free to share them, and then have these discussions with your psychiatrist. And because I think that's part of being open in our profession. We have to be open to our shortcomings as well as our, our accolades on our advantages. We do have something that works just magically. So any questions out there? I'm going to open it up. We got chat.
Hey, Ron, I was
Okay.
gonna, oh, unless you were going to do the chat first.
Yeah, let me just give one question. Dr. Bryant said Lexapro is also indication for children with depression. First was SSRI, was Prozac, came out in the 80s. Okay, great. So thank you, Nicholas. I appreciate that. And I'm glad to hear about Lexapro. I think Lexapro is pretty cool med itself. Okay, go ahead, Christy. I think it was Christy, wasn't it?
Yeah, I was going to say I recently had an interesting case, actually two interesting cases. And one, I was just going to vent my frustration about, I guess, probably my lack of knowledge or maybe just having enough knowledge, and then the psychiatrist not wanting to talk to me about medications or listen to me about the QEEGs. But I recently had a case, a young adult male, 25-year-old with, well, he thought he had ADD, but anyway, he has OCD. And we did his QEEG. He had a lot of fast spindly beta, and he had a high peak alpha frequency. So I did a consult with Jay Gunkelman, and this individual was particularly interesting because he was having lots of interesting thoughts about death and suicide. And interestingly, his sister had literally committed suicide 3 years ago. So it's in his family. So this was concerning, right? Well, he's on this new medication. The doctor put him on Zoloft, and his symptoms started to worsen. And then he's at my clinic. I did a QEEG. We're starting to do neurofeedback. And when I had the consult with Jay, Jay said that, well, he has this high peak alpha frequency. He's got this fast spindly beta. You know, his SSRI for this particular individual's contraindicated. So I'm trying to tell the psychiatrist this, and she won't listen. She wants studies. So I'm so happy to get these studies, and I'll have to pick out the ones that are relevant for her, because she says, I'm doing first line of treatment. This is what you do.
No, and I do agree with you, Christy. This, and Nicholas can chime in here too. This is what is done. And I don't resent the psychiatrist. I praise him, because my God, trying to medicate without data other than symptoms is really tough. And if you can't see that they've got a lot of excessive beta, and you don't know that SSRIs by their nature will increase beta, you know, we have, you've heard of the cases that the first time the person was put on SSRI, they became bipolar. Well, that's the pattern, the very fast alpha and the beta, that you can really flip into a bipolar type presentation.
And that's what he felt like was happening. And
Right.
so, and I, you know, she wouldn't talk to me, and I think it's just frustrating because you know, I really wanted to work with her on that, and I gave her the information about the QEEG, but anyway, it's frustrating.
Well, I tell you that what's really we're running into in the industry, and this has always been that QEEG is very rarely. I mean, it's almost taboo talk in the medical field, unless you're an epileptologist. Nobody in the medical field thinks QEEG is worth anything. Now, we don't need a QEEG to identify we've got a fast alpha peak and we've got a spindling excessive beta. We just need the EEG. So just based on the EEG and the, you know, what the impact of the medicines are, I like to educate the doctors on what the impacts of each medication is on the EEG. There's studies out there for that, and we have nice, beautiful tables for that. And however, you know, I think that there's a lot of other confounding things that can push you in one direction or another. But again, that's a tough part. And by their nature, doctors, we got to give them the respect. I mean, my gosh, you know, they're out there doing their best that they can. And I know that, you know, they don't want some PhD telling them, or some, you know, non-PhD telling them what to do with medications, and it's not. That's why I'm trying to publish these two articles we're about to go to press on, to get that out there in the world psychiatry. So at least they have a baseline for understanding why medications fail. And then you could take that to them and say, this is one of those patterns that's on a failure, and this is why it fails. So that's the part that's going to be the tough part to get through. Is we got to get it into psychiatric journals. That's why I've stopped publishing in our journals, our Ph.D. journals, because unless we get in front of the psychiatrist and peer-reviewed psychiatric journals. I published in the European Journal of Child and Adolescent Psychiatry several times because getting it over here into the United States, it's very difficult. So I'm going to World Psychiatry, at least it trumps the U.S. ones. But Nicholas, do you have anything to add how we should possibly approach psychiatrists and not upset them? I don't know how else to put it. Maybe not. Okay.
Sorry, I'm turning my mic back on here.
Because we really need help with that, and we don't want to upset you guys. That's for damn sure.
Well, I mean, you brought up the research here, and the issue is that it needs to, you have to have the numbers. So a lot of times it's too early in the research. There's not enough power in these studies really to show if this is significant or not. And so when it comes to QEEGs, it's still unclear. There's a lot of studies also showing that it's not helpful. And so until you have enough research really to create a meta-analysis and combine all that together, that's often what it takes to really convince doctors of anything.
I agree, but it's frustrating for us who we have an obligation as therapists to talk to the patient about the medications. I tell everybody, do not ever tell a patient what to do with their medication. That's an MD's decision, but you can inform them as to what the side effects are and everything like this, and be aware, and then feed that information back to the docs when they start experiencing these side effects or whatever side effects they're experiencing. So you guys are informed, well, that might not be a good medication for them because they're having these things that just popped up. I'm seeing them weekly, you see them, monthly or every 3 months, something like that. But yeah, I agree. It's all based in the research, and that's why we have to get it out there. The problem is they started with the pharmaco-EEG studies in the 60s, and it never hit mainstream because they discarded the EEGs. And so quantitative EEGs is just background signals, and the important stuff you can't see in the quantitative EEGs that actually cause medication to fail. So that's been the area that I've been presenting in, is trying to show that the EEG is really where all the gold is, and it's basically getting our foot in the door to give you guys information as to what may help and what may not help. Any other questions out there? Thank you so much, Nicholas.
Hey, Ron, could you give just like kind of a quick, I know this is a big question, a big topic, but a quick kind of rundown of some of the EEG features, not even in the quantitative analysis piece, but just raw EEG features and how that correlates to different medication, either indications or counterindications? Yes,
thank you, Corey. And there's really 4 things. When I started doing research, close to 15, 20 years ago now, the same 4 biomarkers kept popping up in medication failure cases. I thought that was important. So I published a study, and it was 2012. I finished it, hit the journal, the hard copy in 2015, on the 4 reasons for medication failure in psychiatry. And they're really simple and really easy. In all the cases I see studies, and now my study's up to 1,233, the same 4 cases are still coming up. The same 4 biomarkers. And in about 11% of the cases, we have encephalopathy. It's an organically messed up brain for some reason, possibly, or metabolic, toxic issues, or hypoxic issues. In children, tonsils and adenoids that are so big they can't get oxygen at night can thwart the development of their brain and cause an encephalopathy pattern. That can't be seen in the EEG, but it can be seen in the one of my EEGs looked at by 2 different neurologists. And the psychiatrists would never know about this. They act as ADHD as they come, but this is a total population of age 4 to 72. Encephalopathy is a big deal out there in 11% of the cases. So 1 out of every 10 has got an organic issue that no medication will work until you figure out why the body's not supporting the brain. The second one is isolated epileptic form discharges. These are like seizure discharges called by the electroencephalographer, not by me. And there's seizure activity that we know, and the psychiatrists do know, that any medication other than anticonvulsants will actually make them worse. So your stimulants, your SNRIs, your SSRIs, particularly your antipsychotics and lithium, will all make these patients worse. So if they don't know they're there, now we did a study where we had 74 cases between the ages of 4 and 52. They failed multiple attempts at medication, so there were only refractory cases. And we had 85% improved when we switched them off their medications and put them onto an anticonvulsant. Worked beautifully. First study that was ever published on a non-seizure population. The third thing is spindling excessive beta, which we were just having a discussion with just a few minutes ago. Spindling excessive beta is a very distinctive pattern. You have to look at the morphology. You can't really identify it from acute EEG. And the pattern is first talked about in 1950 by Gibbs and Gibbs, who wrote the book in EEG books, manuals, and atlases, and identified it as an irritable cortex or an easily kindled cortex. My recent work in the publication that we're working on right now is we think we've identified this as a neuroinflammatory marker. The reason we think that's important is because the alpha-2 agonist, which is increased blood flow, reduces it. Neurofeedback reduces it due to neutral positive perfusion and neurofeedback. Hyperbaric oxygen does it because it reduces inflammation, it reduces spindling excessive beta, and photobiomodulation. So all the methods that are decreasing neuroinflammation decrease spindling excessive beta. And that we know when there's a certain pattern in EEG for encephalitis, when you're, as you get more and more of an infection in the brain and it becomes encephalitis, they've got this term called delta brush. And what it is that finally the background slows down so much, you just have a delta wave with a bunch of little beta spindles right on the edge of them. And so, again, I think that's where we're looking at. It's a neuroinflammatory response that only an alpha-2 agonist is going to do any good with, and everything else would make worse. So back to Christie's comment about that. Yes, fast alpha and beta spindles are not one that SSRIs will do anything good for, and there's contraindications in the studies about the use of it. But if docs don't know it, they don't know it. And the last number 4 is focal slowing, which we get in people with head injuries, for instance. Part of their brain will be slower than the rest of their brain because of the impact that they had. Sometimes we have a lot of children that just happen to have focal slowing in the left posterior temporal lobe that never had a head injury. And what we're thinking it is there's an abnormal fold or something going on. But we see a skewed population of children with learning issues. So that may be, you can't tell them medicine, just go to that one spot and leave the rest of the brain alone. So I hope that answers it. We got time for a few more questions here, and then we'll have to wrap it up for everybody. Anybody else? What do you want to say? Oh, if there's any ideas out there for topics, we'll leave this on for a little bit so you can put it into the chat. We're really interested in other topics for next month and the rest of the months throughout the year. Hi, Jay-Z. And but we'd really like to get your ideas, because I love, catering to what you guys want. I can't hear you, Jay-Z. Yeah, you're still not on. Yeah. You have no.
Yeah.
Yeah. It doesn't say you're muted, so it must be on your end.
Oh, someone said, can you speak to them?
OCD. Well, in regard to OCD's connection with suicide, rumination, you can get locked in a loop, and that's what it is. Stacey, I'll get yours in a second. You can get locked in a loop, and it's this loop is just a repetitive, what we call in the addiction population is stinking thinking. And all you need then is some sort of lowering of your ability to inhibit your actions. And that's why most people who kill themselves usually drink a bunch of alcohol first, because that lowers your inhibition. So there is a connection between the two. And so, you know, the OCD component of it is can be wrapped up in it, just like it's one of the primary drive mechanisms for addiction. So JC, what did she say? JC said, I was wondering if you could talk a little bit about treatment recommendations for people with ADHD who have big side effects of stimulants. Well, stimulants would make me think that they've got a faster brain than a slower brain if you work with the beta spindles as well. If that, I would probably, if you're not doing an EEG on them, I think psychiatrists might just look at the alpha 2 agonists, because if they've had terrible responses to stimulants, it's probably because they're pushing their brain in the direction they're already too fast in anyway, because it is going to hype them up. All right, what else? Hope that answers it. Okay. All right, guys, it's 1 o'clock. We're going to wrap it up for now. I'd love to go on. I'm going to keep this thing on for a while. I've got a little bit of time here. But if you've got any other questions, let me know. And other than that, thanks everybody for coming. I really appreciate it. And like I say, do email me. Yeah, she's out there. Do email me and I'll let you know what, if I can answer any more questions. Thank you so much. Brooke, thank you for your help. And I'm sorry about Pam. I don't know what happened to her. Stopping recording.